Now, I call upon Dr. Anish Madhavan. He'll be talking to us about the tips to make capsulorhexis and hydro procedures easier.
So good afternoon, everyone. It's about the tips to make a capsulorhexis and hydro procedure. As you know, when you want to become a phacosurgeon, the basic thing or the prerequisite is that you should know how to do good capsulorhexis, right? Of course, there are only three things which you need to make it. One thing, the size should be adequate, it should be central, and it should be round. These are the three things you want to have a good capsulorhexis. Now, this is one instrument which I usually use. This is called a rhexis marker, which is of 5.25 mm. This is very easy because just you make an impression over the cornea, it gives a correct guide for you, and with this guide, you can very well do a rhexis. And I'll show you the rhexis. You can see the rhexis, which is very correct, well-centered, well-sized, and round rhexis. So this is a very simple instrument, and it gives you a really good capsulorhexis. Even for this is a mature cataract, here also you get a good rhexis with that impression. And maybe if you are very good, you don't need any instrument. In that case also you can do a capsulorhexis. But one thing I want to tell you is that whenever you want to make a rhexis, don't go in one shot. It is always better you make it 30 to 40 degree of tear and then move slowly, so you have a more control on your rhexis, and then you can manipulate your size, everything. So that is one thing you have to make sure that don't go in one shot. And along with that, I'll just tell you about hydro also. This is the way I do hydro. You can see the hydro, how it goes. But I usually give it 2 points because 1 point is okay, but most of the time the other end may not be separated well. So if you give it 2 points or at least 2 or 3 points, it will be more easier for you. And there is one thing when you do in the topical phaco, most of the time the patient will move their eye. In such cases, I think this is one thing you can do. You can have a second instrument to stabilize the eye, the globe. And if you are not comfortable to go by the main port, you can have a side port and do the rhexis so that the AC will be well maintained in this case. And here also, I'll just show, this is for just to show the hydro procedure, nothing much to say. So you can see the wave going here. And usually after the hydro, again I said, I'll go the both side and give the hydro. And when I'm talking about the hydro part also, there is nothing much to do in hydro. Only case where you have to be careful in doing hydro is the posterior polar. So in posterior polar cataract, what I do is I don't give a hydro dissection. Instead of that, I do a hydro delineation, so that if your hydro delineation is perfect, what you see is like this. After the cataract, you see a nice epinuclear plate is remaining there as a cushion, and that actually helps you in preventing a rent. All these things everybody knows to make a capsulorhexis, but the most challenging part is an intumescent cataract when you want to do a capsulorhexis. And of course, there are three things you have to manage. Manage the intracapsular pressure, prevent the anterior capsular rupture, and complete a nice circular capsulorhexis. Now, otherwise, you will end up in a Argentina flag side. Now, usually what you do? Usually there are two techniques you do. This is the basic two techniques most of the people do. That is, one, you take a needle, decompress with a straight needle, and the center part is decompressed, and then after that you can extend and do the capsulorhexis. Or else, there is another technique usually people do is you make a small rhexis initially and clean it off, decompress, and then make a second rhexis. But I'll show you one thing. Now the problem I want to tell you is, in this case, you see this is how the intumescent cataract is there. This is the central area where the liquefied cortex is there. You decompress this area. What happens is, this is the original position. You decompress it, the central area will get decompressed, but the mid-peripheral area is not having the liquid cortex. It is actually a fluffy cortex, and it remains as a hill. So after the decompression, you see two hills and a flatter area. This will be the hill area and this is the flatter area. I'll tell you what the reason for that. Now, this is a double rhexis. I have made a double rhexis. I cleaned it, everything. And now I am taking a scissors. Now I am cleaning. 1 second. Sorry. No, not this one. It was a small. Yeah. And now I have to work a second double rexis. Now I am taking a vanasse and cutting. See what happened. So I did everything. Then what went wrong? The thing which went wrong, I'll tell you. This is something I personally feel, this is called the hilltop runoff, because the center area I have flattened, but still that you have seen that mid-peripheral there is a hill. So here you see the moment, now I am doing the rexis, I decompressed everything and now I am doing the rexis. See, the moment I enter into that hill area, my rexis gone into the hill area, there will be a slope on the other side. Whatever you do, I am 100% sure that it will extend. It will extend towards the down. Otherwise, you have to keep your rexis within the valley. You never go into the mid-peripheral area. See, it's gone. And now I will show another video which I have already completed my rexis. And here you can see see, here again, that mid-peripheral area has come up, and here you see a rexis run over. So I personally feel that what you have to do is, whenever you have a intumescent cataract, after you decompress it, take any instrument, whether you have a Sinskey hook or your hydro dissection needle, whatever it is, you just flatten this area. You have to flatten this area, remove this fluffy cortex from here and make the whole anterior capsule flat. And what you can do is like this, you know, after that you make a plateau creation. See, go under it, even with your hydro needle you go under it and just remove all the fluffy cortex from there, make the whole rexis, the anterior capsule flatter. Now you see, even I am making a bigger rexis. This is a bigger rexis which is going into the mid-peripheral area, but still you see nothing is happening. You get a very controlled rexis in this case. So this is one tip I want to tell you when you want to do intumescent cataract. Always flatten it, just break the hill, make it a plateau and do it. So decompress the center, flatten the hill and milk out the mid-peripheral cortex, and always use a blue. Thank you.
Thank you, Dr. Anish. I think the take-home messages from this talk is that you should make an adequately sized rexis. Don't make the rexis very small, then bringing out the pieces will be very difficult. And also you should have a very good corticocleavage hydrodissection so that the nucleus management becomes easy. And also while rotation it causes less pain. And also as far as the intumescent cataract is concerned, if the cortex is very loose, everything comes out very fast. But if there is a fluffy cortex, as shown here, what we can do is after making the primary rexis, don't again hydrodissect because it will increase the back pressure. So you can take an iris repositor or a spatula or something and just loosen up the cortex. And then if you aspirate, it comes out very fast. And also the back pressure means it comes out very fast. You can reduce the back pressure and then go for a secondary rexis. And also while making a secondary rexis, don't make a radial cut. You have to make a slightly sloping cut sort of thing so that it suddenly doesn't extend. And also another thing is, suppose it extends, you don't inject viscoelastic in the center, so that causes further extension of the rexis. So inject the beyond the periphery of the extension, and then you will get a better control. And also you can use the Bryan's little technique. So these were the few take-home messages from this talk.